So I think the most important aspect of this in terms of context is the Marmot Review, which came out in 2010. And I apologise for this slightly busy slide, but it is a sort of resume of a document that's about 150 pages long. It is really the executive summary. Fundamentally, what Michael Marmot, an academic at University College London, was about was reducing health inequalities. And that is really a matter of fairness and social justice. And we know that actually, and apologies, the formatting's gone slightly awry, that there is an additional 1.3 to 2.5 million extra years of life that could be enjoyed by reducing those inequalities. And we all know there is a social gradient in health. When I was a medical student, Julian Tudor Hart, who had moved from being an academic in Cambridge to being a GP in South Wales, devised this idea of the inverse care law, which really meant that actually the poorer you were, the further you were away from good care. So that there was almost an association between affluence, employment, all of those social determinants of health, not just access to healthcare, but more importantly, access to housing, a job, and decent education, that really made a very big difference for this social gradient in health. And Marmot then exemplified that through his report. And a fair distribution of health, well-being and sustainability is an important and reasonable social goal. The report set out 6 policy objectives, I think many of which you'll probably be aware of, but giving every child the best start in life, enabling all children and young people and adults to maximise their capabilities and have control over their lives, creating fair employment and good work for all, ensuring a healthy standard of living for all, and creating and developing healthy and sustainable places and communities, important emphasis there on place, and strengthening the role and impact of ill health prevention. So this is much more about the things we can do before people get to a hospital or need healthcare. And if we could sort all of those, I think many of the woes of our National Health Service would go away. So delivering those objectives became important as an action by central and local government, and the work was commissioned in 2010, as I say. It was then reviewed. If we just go to the next slide, in 2020, by the Health Foundation, and in fact an update from Marmot himself more recently. And sadly, not a huge amount of progress was made. So people can expect to spend more of their lives in poor health. We may be living longer. And in fact, for the first time, the current generation are not living longer than the previous generation. We've actually stalled in terms of life expectancy and gone backwards in some groups. But actually, although people may have been living longer, they weren't living healthier lives. And improvements to life expectancy have declined for women in the most deprived 10% of areas around England. The health gap has grown between wealthy and deprived areas, and it's clear that where you live, the place you live in matters. If you're in a deprived area of the northeast, your outcomes are likely to be worse for your health than living in a similarly deprived area in London, to the extent that there's about a 5-year gap in life expectancy. And I'll say a little bit more about those huge variations in life expectancy in the next slide, particularly with emphasis on Kent and Medway. So some of the takeaways, sorry, if we just go back quickly. Apologies, Alice. The service user engagement is essential before an intervention can be implemented. And if you think about vaccine hesitancy, if you think about smoking cessation, think about some of the choices people make about their lives, you need to engage them to be able to offer proper preventative healthcare. And in fact, recently at the American Society of Clinical Oncology conference in Chicago that's happening at the moment, there was quite good evidence that we're going backwards on colorectal cancer, that we're seeing more colorectal cancer in younger people. Now, that may be because we've had some successes in smoking cessation and in heart disease, but it does reflect that we're not necessarily enabling people to eat better food and have, really be aware of the impact that food has on cancer risks, and not just GI cancer risks, but other cancers. We also know that cost of living challenges are contributing to poor health. This is personal for me. I have a daughter doing a PhD in public health at the moment, looking at housing and health outcomes. So when people choose, do I heat my home or do I spend money on food? They often choose the latter, but actually to keep their weight in a more normal range and choose to heat your home is probably a healthier choice. My own personal experience as an oncologist was when I started campaigning for treatments for cancer that was £6,000 per patient and offered the potential for an extra year of life. That really did seem worth getting out of bed for. But when I then had to campaign for £50,000 worth of treatment in the adjuvant setting, i.e., where you didn't know whether the patient would definitely benefit, but it would probably improve their life expectancy, I started to think, well, actually, it costs £200 to offer somebody a smoking cessation service. So 50,000 didn't really seem like very good value. And it was part of my own journey, really, of thinking why actually what we deliver in the community and the lifestyles that we offer people is far more important. So if we just go to the next slide, which shows you some quite wide variations across Kent and Medway. And you'll see the green blobs are those mostly towns actually inland, with the exception of Whitstable, where we can see life expectancies of, in males of 81, 83, etc., 82. But if we move then out to the coastal towns, and we know that this is an issue around the coastal towns across England, not just in Kent and Medway, we can see really quite big variations. So life expectancy at birth for males is higher in the more central built-up areas, and it's lower in the outer and coastal towns. So in Chatham, for example, you have a life expectancy of 73 compared to 81 in Cranbrook. That isn't because life's fundamentally different. It's probably to do with all of those different social determinants of health that I mentioned before, employment, education, affluence in general, diet, etc. So this is, I think, really quite significant, and we have not made progress on this in spite of being aware of it. If we just go to the next slide. This is a similar representation. Lord Darcy, in 2010, with his report Healthcare for London, looked at male life expectancy and female life expectancy as you go east on the Jubilee line. And approximately for every stop you go east, you lose 1 year of life expectancy, both for women and for men. Again, we're talking a distance of 7 miles, and yet 7 years in a difference in life expectancy outcomes. You just go to the next slide. So when I joined PA, and one of my reasons for joining PA was that alignment of healthcare and life sciences. I saw it as the opportunity for the life sciences industry in its widest sense, not just big pharmaceutical companies, but small medtech startups, smaller social care organisations that were using innovations to actually improve, work together to improve outcomes. One of the most exciting things was about 2 months after I joined, we won a piece of work with NHS England called the Place Development Programme. And that was designed to work with all 42 of the integrated care systems. We did actually work with 40 of the 42 at a place level. So each had designated at least one place, in some cases 2, where we would focus on what was happening for that population at that place. And this was 4 modules. It included leadership, included finance, it included data. And I've just put here 3 or 4 of our case studies where we worked with people on the ground over a period of about 6 to 8 months to understand what data they had and then how that data could be aligned. So it was really about taking multiple data sets and aligning them so that we had more information about people and their long-term conditions, their physical and mental health. This one happens to be, happily from the Toby connection, to be in Rotherham, where we looked at individuals suffering from multiple long-term conditions. I think the important point here is people who live unhealthy lives in later life often have not just diabetes, but they have diabetes and heart disease and renal failure, all of which are, of course, interlinked. But they probably also have stressful lives that may give rise to mental health conditions. And of course, we were doing this piece of work towards the end of the pandemic, which was adding the stress and pressure on people as well. So we work with GPs, pharmacists, commissioners, analysts, and the local council, and importantly, the voluntary sector, to look at the challenges faced by individuals. We identified a series of outcomes for those individuals, and then we recognised that greater service user engagement was essential. So we worked to establish a task and finish group to take forward the engagement activity, develop a case for change, and then consider how to fund this across the system to gain deeper insights. If we just go to the next slide, and I'll skip through these because to keep up to time. This was one where, when we said to our wider group, and it was a consortium of 10 organisations, so not just PA Consulting, we worked with Solace, with Optum, with IBM, but also with the Social Care Institute for Excellence and the National Association of Primary Care, amongst others, and Collaborate, which some of you may also have heard of, which works widely with local councils. What came forward on this was both actually in Dorset and in Kent, but particularly importantly here, Kent County Council, was that there was real concern about 2 deprived wards in Maidstone, where there was sort of issues of mental health, diabetes and pre-diabetes. And, you know, this quote at the top, why would I buy a nice chicken breast for myself for tea when I can get a large pack of frozen sausages to fill all the family? So making unhealthy choices as opposed to healthy choices. And community engagement was obviously very important here. We were a bit cynical as to whether actually doing stuff about food security or food insecurity would make a difference. And we were really pleasantly surprised. We understood that people were unwilling to rely on food banks and because of the stigma associated with it. Whereas when they set up a community larder on a pay what you can basis, that gave people greater sense of pride and not the same level of stigma. So we moved towards a community larder, which was a hub for other health and social care services, including mental health support and diabetes management. It was a real success story of working locally on the ground with the population, but also with many other players, including, as I said before, the voluntary sector. If we go to the next slide, there's an interesting comment in the chat, so thank you. He's an inspirational man, Michael Marmot. I will never forget the 2010 launch of his report, not just his talk, but actually some of the actors that were present at it, sort of looking at the differences in lives between people who have poorer life expectancy and better life expectancy. This was really looking at the waiting lists in West Suffolk. There was real concern that the waiting lists were helping the worried well, or not the worried well, but those who could better articulate for themselves, and that actually there would be a disadvantage to people who came from more deprived areas. So we set up a working group and took 73 different patients, 72 of whom had raised concerns, and we signposted them to other services. So while they were sitting on the waiting list for 18 months, 2 years, that sort of order of time, we were able to offer, or rather the local healthcare system was able to offer much better support, some of it encouraging people to take more physical activity. And as a result, not only did we get really positive feedback, but actually some people came off the waiting list and no longer needed their knee or their hip replacement because we'd been able to offer exercise and make them fitter and reduce some of their issues. We still know that 25% of knee replacements actually have a deterioration in the patient-reported outcome measure. So for 25% of patients who might think they need a knee replacement, there could be a better way. If we just go to the next slide, which I think is one of the last. So this was a piece of work. Again, this was one of those 40 systems. We worked with about 30 of them to identify particular projects. This was in the Black Country, where we identified families, and the Black Country being the second most deprived integrated care system in the country. We identified families with children under the age of 2 who were at risk of adverse childhood experience. We used a whole series of different data sets, including health visitor data, family nurse partnerships, local authority data on and other statutory children's services. And we looked at we cleansed the data and consolidated it around geographies. We also spoke to many multi-agency professionals, including social workers, and focused on 13 families to understand what the needs and potential interventions might be, having got this down from an initial cohort of 300 families. And we then identified 6 GP practices where there was data on parental mental health needs as well. And so often these issues, risks of adverse childhood experiences, are not about obviously just the child. They're very much about the much wider system and the family. And you can see from those that data we used on the left, we were able to target those families and as a result improve their school readiness, which in itself is a good proxy for better outcomes.